Vidya Bhatt is
Vidya
there.
Bhatt ma'am also, yes sir, she's logged in.
Yes.
Vidya Thobi madam also logged in. Rajashri Paladi and Suman Gaddi ma'am.
Yeah.
They've all logged in, sir.
Yeah. I think Dr. Sonia, I request you to proceed with the webinar and please introduce Dr. Hitesh Bhatt, first speaker. And this webinar we have planned with the objective of that how as a doctor OBGYN we should safely practice. And secondly, if we want to bring down further maternal mortality, it is the preeclampsia which we need to address. So with that in mind, we have taken these two topics. So I request Sonia to please go ahead. Vidya, but would you like to add anything? Please go ahead.
Yes, sir. We will take it on flow, sir.
Yes.
Yes. Thank you, sir. And as a formality, and we start with this webinar. Namaskara. Good evening, all. It's my absolute pleasure to welcome you all to this insightful webinar on behalf of KSOGA and KCOG family. Today, we have the privilege of learning from esteemed national speakers who will bring a wealth of knowledge and experience from their own fields. May I now request Mr. Arun from the KSOGA office to play a player video just to set a serene and a positive tone for the webinar. Thank you, Arun. With blessings from our patron, Dr. Hemji Hiramat, maybe he will be joining us in a while, and our past president of KSOGA, Dr. Vidya Thobi. We are here with the theme of KSOGA 2025. We all know that it is promote wellness and prevent illness, which is coined by our president, Dr. Bharti Rajshekar. May I now request Madam to extend a warm welcome to all the participants and also introduce the significance of today's topic.
Thank you, Dr. Sonia. Namaste to all my dear custodians. We extend a warm welcome to Dr. Hitesh Bhatt, who is a renowned medical legal expert of Foxy, and Dr. Ramani Devi, who is another doyen in obstetrics and gynecology and in the Foxy. And today, we aptly, Dr. Epi Bellar and Dr. Vidya Bhatt and Dr. Sonia have chosen two very important topics which are of very significant importance in our day-to-day practice. One is the screening for hypertensive disorders in pregnancy, and we have come a long way in identifying and predicting those who will be prone for hypertensive disorders of pregnancy, and we can prophylactically prevent the known fetal and maternal complications by appropriate screening at the appropriate time and putting them on prophylactic drugs such as ecosprin so that we can have a better fetal and maternal outcome. And that's a very well chosen topic which Dr. Ramani Devi will be speaking. And of course, medical legal issues, I think it is the burning topic because each one of us at one point or other, we are either apprehensive about whether we have a litigant in our OPD or any other case, there is some complication. We are worried not only about the outcome of the surgery and the patient's revival. At the back of our mind, we always have this sword hanging on us, and we keep wondering: is this person going to be a litigant? Will there be a litigation? Will there be any legal proceedings? How do I come out of this, or how do I save myself and my practice from medical legal litigations? And Dr. Hitesh Bhatt is an excellent extempore speaker with vast practical knowledge, and it is good that he will be highlighting us about how to keep ourselves safe, how to protect ourselves, or how to fight for whatever cause or for whatever negligence we have not done, and see that justice is given not only to the medical practitioner. Of course, it depends on how we need to safeguard our interests by proper documentation, following the proper protocols, and if at all there is a litigation, what exactly we should do so that we do not encounter any such any problems or any exorbitant compensation.
I think there is a network issue, and we have already heard from Dr. Bharti, our president. Thank you so much, ma'am. With permission of Dean of KCOG, Dr. Bellat, and Chairperson KCOG, Dr. Vidya Bhatt, ma'am, do we start the scientific deliberation?
They're all muted.
Yes.
Sonia, I
No,
think
no, go ahead,
we
go
should
ahead,
start.
go ahead.
Okay, ma'am. So I now
Yeah.
request the Secretary of KSOGA, Dr. Rajeshri Palladi, to introduce today's first speaker, Advocate Dr. Hitesh Bhatt. Ma'am, please unmute. You're muted, ma'am. Yeah.
Good evening, everybody, and welcome to this important meeting today. We are indeed honored, and it's a proud privilege for us to have with us Dr. Ritesh Bhatt, who was solicited to be our speaker and addressing this gathering. And it's my proud privilege to read a few brief CV about him. At present, he's practicing at Andheri East in Mumbai and medical legal consultant since last 23 years. Medical legal consultant at Wadia Maternity Hospital, Mumbai, and medical legal consultant at Central Railway Hospital, Mumbai. Partner in legal firm in P&S Medical Legal Consultants. He's the past chairman of Ethics and Medical Legal Committee of Foxy for the year 2013 to 16. And sir has been the authored books like Consents in OBGYN and Law, which a doctor must know. The website is given here, and he is invited as a national faculty at many national and state conferences and has delivered more than 1,600 talks, which is a huge deliberation. Medical legal consultant to 250 hospitals across India, and he has served as office bearer for the IMA, AMC, MOGS, and AFG, life member of the Film Writers Association, Mumbai. So with such credentials, I'm sure that we indeed will have a very, very active and interactive deliberation, and we are honored to have him to address the KCOG of Karnataka. Thank you so much. Welcome, sir.
So, good evening, and thank you for inviting me. I'm not starting my video because I'm put up in a hotel. It's a good and it is not, excuse me. And if you cannot hear me, just give me a call on my mobile number, which Sonia is having. So with this, let me share my presentation.
Go ahead,
You're
Hitesh.
audible, sir.
Hi. Can you see my
Yes, sir.
my
Yes.
screen?
Yes, sir.
Just a minute, but it is stuck. I'm not able
There is
to.
no PPT. There is no PPT.
There is no PPT. That is what I'm also searching for PPT. It's not coming.
Hitesh, plus first you open the PPT and then
Yes, sir. That is what I have done. That is what I have done. Wait, these are all technical issues.
all the consultants and postgraduates, this is very important because you are going to be in the era where your records are going to save you, and this is what Dr. Hitesh Bhatt is going to say to us, as well as in his experience, vast experience. He's a doctor and lawyer, and that is what Hitesh, I also want to do that.
So now I think it should be there, right?
No, sir. Your screen's not shared.
It is showing here. There's some problem.
Dr. Hitesh, you can mail that to Dr. Sonia.
Yeah,
She
that's what. Can you share that, sir? Or can you
Yes.
email me? I'll just send you mail ID. Oh, yes.
No, that's okay, madam. The problem is not that. Wait.
Yeah, now we can see.
Now we can see.
Presentation, right?
Yes, sir.
Yeah, but it again, yeah.
Full screen, sir.
So it takes little time. That is the only problem.
Now we are able to see but you have to put it in a slideshow.
Yes, I'm doing that only. My cursor is not coming on the screen because of so many. Okay. And is it
No.
there?
Yes, sir.
I don't know why it is acting funny. Anyways, so I can even talk without the presentation, then that is the only way to go ahead.
No, you can share your presentation screen without the slideshow.
Sir, just a minute. Because the
what you do, sir, is just stop screening and first open the presentation and then start.
It is there. It is there. Wait, now it will come for sure because the things have settled. The cursor goes. That is the problem. The cursor is not visible on the. Anyways, let me just talk, sir. Okay. Now it should come. Right?
Yes. Yes.
Is
Yes.
it there? Okay.
Yeah.
So, medico-legal issues in the OBGYN. Now, there are so many issues in our practice, but we are talking today about the issues which can lead to medico-legal problems. So, what is medico-legal? First, we have to understand what is medico-legal issue. It is any legal action which arises against a doctor for the professional services rendered by him, or any kind of involvement of a doctor is required in any legal proceeding. That case is called medico-legal case. So there is no separate category. It is whenever you are called in a court or as a witness or as an accused, that is a medico-legal case. So there is no specific definition. So by this definition, every case is a potential medico-legal case, because if that patient goes to court, it becomes a medico-legal case. Also, there is nothing like medico-legal. That word is also coined by doctors. We are always seeing some legal issue. We don't have words like engineer or legal, architect or legal, professional or legal, but only doctors have coined this term medico-legal. But otherwise, anybody can be under the ambit of the law and it can affect any professional. Now, what all type of litigation that can be filed against an OBGYN consultant? Why I'm telling OBGYN? Because there are certain laws which are specific to OBGYN. Otherwise, consumer litigation, criminal litigation, PNDT related, MTP related, medical counsel, human rights complaint, complaint from the Pollution Control Board, birth and death registration default, or ART and Surrogacy Act. All this can, at all these places, the complaint can be filed against an OBGYN specialist. and medical legal cases are constantly increasing. Almost 100% rise
Dr. Hitesh,
every year.
Dr. Hitesh,
So,
you have some internet
and that is
issues.
because of the increasing awareness of due to media and internet, decreasing
Dr.
yes,
Hitesh, Dr. Hitesh, can I interrupt for a second?
yes, sir.
Your internet is not appearing nice
Yes,
because
sir.
you are breaking in between, please.
Yes, sir. Yes, I'm very sure because this is the best internet I can get. I'm in a hot internet.
Hello, hello.
Yes, sir.
You are not clear.
Sir.
Your voice is breaking. I mean, maybe network issue. Please see that you are in a good network area.
Sir, this is internet. I don't have internet. I'm in, and this is the. Hello.
Hello. Sometimes it
Hello.
is good. Sometimes it is not good.
Hitesh sir got disconnected, sir.
When I just spoke to Sir, I just called him. He said without the slides he's going to speak. He'll just get directly connected from his mobile. Meanwhile, can we actually switch over and start the second talk, sir? Madam Ramani, ma'am. Namaste, ma'am. Good evening. She's already logged in.
Yeah, I saw her. I just logged in. I think that should be fine.
That should be fine, sir, because.
But you tell him, please.
I'll just speak to him, sir.
Yes. Dr. Ramani.
I am ready, sir.
Good.
Good evening, everyone.
Good evening.
Good evening, Bhalan sir, Sonia, and others, Dr. Bharati, Dr. Vidya, and all my good friends from Karnataka.
There is some network issue with Dr. Hitesh. I think Ramani, you can take over if
Yes, I am ready. I am ready.
Yeah, please keep ready with your slide screen
Yeah.
on. Yeah.
Everything is ready. I can just share it.
Sure. Audience, please excuse us because this is due to network issues.
Sir, I think we'll proceed because I'm not getting connected to sir.
Yeah. Ramani Madam can
yes,
say.
Sir. I now request our chairperson, KCOG Madam Dr. Vidya Bhatt to introduce a most iconic obstetrician and gynecologist of Tamil Nadu and South India and India, the national level, Golden Aim Awardee, Madam Professor Dr. Ramani Devi.
Thank you, Sonia. Can I come in? Sonia?
Yes, madam.
Yeah, can you hear me? Am I audible?
Yes, you're audible.
Yes, you are very much audible.
Yeah. So it's a great pleasure to introduce Ramani Devi, ma'am. She has a lot of achievements and she has done a lot of work in endometriosis. You can see all that in the slide, but at a personal level, I know Madam very well, a very dynamic lady. And during her tenure as endometriosis committee chairperson, she has done wonderful work. She has published a lot of books, articles, and a lot of guidelines in endometriosis. And she has been the past vice president of FOXI In that tenure also, she has done tremendous work. Endometriosis conference, I think I was a part of her and Dr. Kanti's conference. So it's a great pleasure to introduce you, ma'am. And any topic you give to madam, she'll do full justice. That is what I like about her. She gives a lot of information, and her work, what she has done in that particular topic. So the other, whatever is there in the CV, I think that is too less to talk about her. So over to you, madam, for your topic on screening in hypertensive disorders.
Thank you, Dr. Bharti. It's a pleasure to be with all of you this evening. Can you see my slides?
Yes, yes, Dr. Ramani, we can see.
Okay. Yes, ma'am.
You have to make it slideshow.
Yeah. I think now you can see. Yeah.
Yes,
Okay.
ma'am.
So routinely, everybody thinks that I do most of the times endometriosis, but my passion in obstetrics, mainly on hypertensive disorders, is something immense because as a postgraduate during my MD tenure, my thesis was how we can detect hypertensive disorders, how we can differentiate preeclampsia from hypertensive disorders just by doing an echocardiography and measuring the left ventricular muscle mass. So that was in those days, probably it was some 40 years back, and that was first time published in the American College of OBGYN journal. So I thought, why can't I replicate? Because that was the first time, earlier days, where we had echo available in our own postgraduate center. So now today we have even advanced beyond that, and there are now biomarkers which can predict, which can diagnose, and which can help in the management of preeclampsia. I'll be giving my talk under the following headings. Introduction, what is the frequency of preeclampsia and diagnosis and pathogenesis, preeclampsia risk factors, complications of preeclampsia, biomarkers that are used to predict preeclampsia during pregnancy, role of SFLT1 to PLGF ratio, how we can, based upon this biomarkers, how we can plan our therapeutic management, and what will be the future directions towards early diagnosis, towards management and future complications and conclusions. So hypertensive disorders of pregnancy is the most common medical complication of pregnancy. In India, 12 to 22% of the pregnant women, they have HTP. The incidence of preeclampsia was found to be 10.3% according to National Eclampsia Registry in 2013 by Foxy. 18% of the maternal mortality rate and third cause of maternal mortality rate is due to hypertensive disorders of pregnancy. Approximately 1/3 of the hypertensive disorders are due to chronic hypertension. And spectrum of disease, it ranges. It can be a mildly elevated blood pressure without minimal, with an insignificant clinical significance, or to a severe hypertension with multi-organ failure. ACOG says hypertension can be diagnosed without proteinuria, and we also now, our Foxy guideline, Gestosis guideline, ICOG, everybody says just a mere increase in the blood pressure without proteinuria can pick up hypertensive disorders of pregnancy. Preeclampsia is a multifactorial pregnancy-related disorder that is characterized by hypertension and proteinuria after 20 weeks of gestation. The early detection, prompt treatment of preeclampsia will result in favorable prognosis for both the mother and the fetus. So what are the causes for maternal mortality in India? Previously, in about some 2 decades back, we say that hemorrhage is the most important cause for maternal death, that is followed by sepsis, followed by hypertensive disorders. But we know that majority of the postpartum hemorrhage have been effectively tackled by proper management, because we can detect it earlier and we can treat it. Followed by sepsis. Of course, sepsis we are able to control with proper aseptic precautions we take during labor, as well as the antibiotics that are available. And the third important cause, that is the hypertensive disorders are slowly increasing. And we find the most important cause for maternal mortality, to say that in our Tamil Nadu, it is found to be second only to hemorrhage, and there is only a meager difference between the hemorrhage and the hypertension. So now let us classify hypertensive disorders of pregnancy. If it occurs less than 20 weeks of gestation, it is probably chronic hypertension. And if you see beyond 20 weeks of gestation, it could be either a gestational hypertension, or it could be a preeclampsia or eclampsia, or it is a chronic hypertension that is superimposed with preeclampsia. So then the pregnancy-induced hypertension, we have gestational hypertension, where there is blood pressure is just beyond 140/90. There is no evidence of underlying cause for hypertension, no associated symptoms like proteinuria or end organ damage, and it comes to normal within 6 weeks of delivery. But you have to remember one thing. These are the group of people who are again prone for late onset hypertension. Then comes the most important group, that is the preeclampsia, which can be again in two ways. That can be non-severe or it can be severe. And there is no, we don't have mild, moderate, and severe. It is only mild and severe nowadays. Then comes eclampsia, where there is presence of associated convulsions and coma that is happening along with preeclampsia. So now let us see what ISHAP classification, that is International Society for Study of Hypertension in Pregnancy classification. They say that if it occurs before 20 weeks, it could be chronic hypertension, as it was mentioned earlier, or we have two more things, that is white coat hypertension or a masked hypertension. In white coat hypertension, what happens is the patient gets hypertension only when they see the doctor. But whereas it is in masked hypertension, when they are visiting the consultant, the blood pressure may be normal, but at home it may be high. And in the chronic hypertension, we have to again subdivide whether it is basically an essential hypertension or whether it is secondary to renal problem or anything else, pheochromocytoma or so many other causes for chronic hypertension. Then hypertension that occurs de novo after 20 weeks of pregnancy, it can be still a transient gestational hypertension, which just comes and goes, or it can be a gestational hypertension, or it can be a preeclampsia that occurs de novo, or it can be superimposed upon the hypertensive disorders. And why preeclampsia has to be differentiated, whether it is late onset or early onset? Because there are a lot of differences. Early onset preeclampsia, otherwise it's called as EOPE, where here the maternal complications are very severe. Abnormal uterine and umbilical artery flow starts occurring in the mid-trimester. There can be low birth weight, fetal growth restriction, necrotizing enterocolitis, intraventricular hemorrhage, and iatrogenic prematurity are very common, and placental dysfunction is the common cause for early onset preeclampsia. When it comes to the late onset preeclampsia or LOPE, the maternal complications are very less severe. There can be a normal uterine or umbilical artery flow in the mid-trimester or even in the late third trimester. Low birth weight and FGR are less common. But here we should note that cardiovascular dysfunction is the cause for late onset preeclampsia. So now first thing is we have to understand how we should take a proper blood pressure measurement. The patient should be comfortably seated, relaxed, use the correct cuff size. For the larger obese woman, you have to have a cuff size that is larger, and for a thin woman, it should be appropriate for them. And we should avoid vena cava compression when supine. Left lateral decubitus is often ideal when the patient is not able to sit, and reading that should be taken to the nearest 2 millimeters of HCG. Yeah. Then HC. Then diastolic blood pressure should be at corresponding sound 5. If K sounds heard till 0, then you have to make a note of K4 as well as K5 level to be mentioned. As for example, if it is at 140 systolic, diastolic K4 is 70, and K5, it happens even at 0. Then if the blood pressure is greater than 140/90, we have to repeat the reading 4 to 6 hours apart. And if the blood pressure is first initial reading is greater than 160/110, the second reading should be repeated immediately, that is 15 minutes apart. Then this is the left lateral recumbent position, what it should be measured. Then as per the National High Blood Pressure Education Program, what is acceptable as a normal or an acceptable blood pressure is a systolic BP of less than 140, diastolic BP of less than 90 mm of Hg. And mild hypertension is when the systolic blood pressure is between 140 to 159 and diastolic is between 90 to 109. And in severe hypertension, when the systolic BP is more than 160 or diastolic BP is more than 110. So now there are certain differences between mild versus severe preeclampsia, but BP is not always a dependable indicator of severity, because a patient who is having a blood pressure of less than 159 bar 109, still he can have the severe preeclampsia because of the associated multi-organ involvement. The abnormality, that is in headache, is usually rare in mild, but it's present in severe. Visual disturbances are present in severe preeclampsia. Likewise, eclampsia is more common, but still it can happen in a mild preeclampsia. Also, upper abdominal pain, pulmonary edema, and proteinuria persistent beyond 2+ or more. And oliguria is more common in severe preeclampsia, and creatinine level may be elevated, and thrombocytopenia, it happens in severe, and then hyperbilirubinemia or LFT alteration can be there. And then fetal growth restriction is more common in severe type of preeclampsia. In severe preeclampsia, as I have described earlier, systolic BP should be more than 160 and diastolic should be more than 110 millimeters of mercury. And there may be a severe proteinuria greater than 5 grams per 24 hours. And the severe symptoms like right upper quadrant pain, epigastric pain, headache, blurring of vision, and sudden increase in the weight. I think we should give importance to the sudden increase in the weight. For example, if a patient coming in the previous visit has got certain weight, and if there is a sudden increase, say beyond 2 to 3 kg within 30 days of her previous visit, then we have to think in terms of impending preeclampsia for that patient. Again, there can be abnormal laboratory findings like thrombocytopenia, elevated liver enzymes, and elevated creatinine. So now, what is the etiopathogenesis? We do not still have any clear idea about why the woman get preeclampsia. But the possibilities are there could be a defective trophoblastic invasion that has been found to be the most important reason and a most important cause for variable involvement of the multi-organ involvement. And again, there is an imbalance between the angiogenic and anti-angiogenic growth factors like VEGF, PLGF, SFLT1. Then there could be a genetic predisposition. Like if the mother has got a preeclampsia or sisters have got a preeclampsia, then the chances of that particular index patient has got a higher risk of developing preeclampsia. Aberrant maternal immune response to gestation is again found to be one of the probable reasons. Now, this diagram will show you, this is a standard diagram where we find in any textbook. Here is in a non-pregnant stage where the spiral arterioles appear. And in a preeclampsia, what happens is this. Now, in general, in a normal pregnancy, there is invasion of the trophoblastic tissue, which will make the spiral arterioles wide, and there is decreased sensitivity to the circulating angiotensin. And the spiral arterioles are made very wide. But whereas in women who are prone for preeclampsia, the second way of syncytiotrophoblastic involvement and the cytotrophoblastic involvement is altered. Because of that, there may be narrowing of the spiral vessels. So here again, there is the most important reason for all these problems, vasospasm, everything is will lead to endothelial dysfunction. Normally, whenever there is increased levels of placental growth factor and reduced SFLT1, what happens is there is the endothelial system is in a good health and it is relaxed. But whereas in patients who are prone for preeclampsia, where there is elevated SFLT1 and S-endoglin, and where there is reduction in the PLGF, then you can say that it will lead to endothelial dysfunction and causes impaired relaxation. So there are stages of preeclampsia as you go about in the pathogenesis. In normal, in the healthy endothelium or without endothelial dysfunction, there is upper limit of this VEGF and PLGF are increased, but whereas SFLT1 is decreased. But whereas in women who are prone for preeclampsia, it becomes reverse. And in early stage, there is definitely a narrowing of the spiral vessels and failure of the second wave of trophoblasty involved, and where there is the tilt in the balance of SFLT1 to VEGF, and this will damage the endothelium, and this can lead to eclampsia, HELLP syndrome, proteinuria, fetal growth restriction, and edema. So the same thing is being explained here, where in the stage 1, incorrect implantation or failure of the second wave to invade, this can lead to impaired trophoblastic invasion and insufficient chiral artery modeling that will lead to extensive oxidative stress and abnormal placental perfusion and abnormal development and defective morphology of the placental villi. But in stage 2, the disturbed angiogenic balance is more marked, and it can lead to all changes, increases the mother's lowered values of prostacyclin. There is when you take into consider the prostacyclin, the vasoconstrictive prostacyclins are more than the vasodilative ones, and there is also activation of the maternal coagulation system, which will lead to endothelial dysfunction, causing hypertension and glomeruloendotheliosis, which is the hallmark change in the kidney that will lead to proteinuria and, of course, multiple organ failure when the preeclampsia becomes very severe. So here again, basically, it has got some genetic factors, what I have mentioned earlier, and oxidative stress is increased, and then you can get the alteration of the NK cells, and there is angiogenic imbalance is there, leading to hypertension and alteration in the renal function, leading to proteinuria, and then placental dysfunction affecting the fetus, and cerebral edema and liver dysfunction. So this again, there is the pathogenic pathways are angiogenic pathway where it is altered, and there is increased sensitivity to the circulating renin angiotensin aldosterone system, and the inflammatory factors like tumor necrosis factor alpha, IL-6, HLG, all these things are elevated, and the hormones, the abnormalities of the hormones, like there can be hyperinsulinemia, hypothyroidism, and altered progesterone levels. Then genetic factors, of course, they are overexpressed, and fetal factors, there is circulating cell-free fetal DNA, alpha-fetoprotein, and PAPA are all elevated. And nowadays, we give much of importance to this epigenetic factors, that is microRNAs, methylation, acetylation, and histone modification. The microRNAs in future will definitely emerge as a much earlier biomarker for a woman who is prone for preeclampsia. Other molecules like amyloid protein, creatine, and adipsin. So these are all the basic pathogenic pathways. So what is the impact of hypertensive disorder upon the maternal organ? We have mentioned again the placental abnormality will lead to fetal complication, and the renal problem will lead to glomeruloendotheliosis. And now I would like to add up the most important organ that is similar to kidneys, cardiac alteration. Cardiac changes happens, which will lead to altered myocardial wall and damaged cardiomyocytes. This is found to be very important because these hypertensive disorders, which are recurrently occurring in subsequent pregnancies, if they are not monitored properly, this woman is likely to go in for an heart failure or a coronary artery disease at a later stage. So what is the adverse effect of fetus and the mother? We have studied already persistence of this BP, liver dysfunction, renal dysfunction, and thrombocytopenia. This is the reason why the women with severe preeclampsia and multi-organ failure, they will go for HELLP syndrome, and pulmonary edema can happen, seizures, non-epileptic seizures can happen, and a long-term cardiovascular complications, which I have mentioned. So look at the platelets. How platelets are involved in preeclampsia? It is platelet gluttony targetable for antiprocoagulation. Suppose you see a non-pregnant patient, there is a hemostatic plaque, and the unactivated platelets are there. They are having a smiley look. Then comes a healthy pregnant patient, where again you can see this unactivated platelet. And then when you are coming to gestational cusp of this healthy pregnancy versus gestational hypertension, you see this platelet becomes abnormally, they look weird, and they are primed platelets. Again, once when the woman enters a phase of preeclampsia, there may be an activated platelet expressing facultative glucose transporter 3, which will engulf all the platelets. That is the main cause for coagulopathy to occur. So now the future thing is whether we can use some anti-procoagulation to reverse the preeclampsia. Now let us see what are the summary of the risk factors. The group of risk factors can be either based upon the demographic or the family factors, increased maternal age of 40 years or older, preeclampsia in the family, mother or sister, early occurrence of cardiovascular disease in the family. For example, if the mother has got an ischemic heart disease or a cardiac failure, at the early stage, say at 40 plus, then the chances of that particular index patient likely to have a higher incidence of preeclampsia. Medical history, preeclampsia in previous pregnancies, antiphospholipid antibody syndrome, previous pregnancy, hypertension, renal disease, diabetes, low birth weight, congenital thrombophilias, elevated triglyceride values. That is why we have to give importance, especially obese individuals with an abnormal lipid profile. They have a higher chance of preeclampsia. Using cocaine or methamphetamine, history of pregnancy loss before 10 weeks. So rather, I would say any adverse effect of pregnancy during the previous pregnancy, the chances of adverse maternal long-term complications are going to be high. Then comes the current pregnancy, multiple pregnancy, new partner, use of ART. This is again use of ART because it is especially the donor oocyte program, or when the mother is of higher maternal age, the chances of preeclampsia is quite high. And the long interval between pregnancies, that is more than 10 years, and when the systolic blood pressure of 130 or higher, or a diastolic of 80 or higher at the first visit, make a note that patient has to be followed up carefully. Bleeding from the genital tract. So this is an adverse early pregnancy outcome. There also the chances for preeclampsia is high. Pregnancy with a trophoblastic disease and abnormal biomarker values in the first trimester. In the current pregnancy, during the second and the third trimester, include blood pressure, abnormal values of alpha-fetoprotein, chorionic gonadotropin, inhibin A, and estrogen, excessive weight gain. This is a very, very important practical sign. And infections complicating pregnancy like urinary tract infection or intrauterine fetal growth restriction, and abnormal Doppler of the uterine vessels as well as the umbilical vessels, and abnormal biomarkers. So again, the risk factors are chronic renal disease, hypertension, obesity, and diabetes. And stage 1 is less than 24 weeks. Here we have certain biomarkers which can be picked up for each trimester. For example, in the first trimester, the biomarker can be PAPA, PLGF versus SFLT1. And in imaging, you have to measure the uterine artery Doppler. In the second trimester, the biomarkers added are VEGF, PLGF, and then PAPA and S-endoglin. And in the imaging, the uterine artery Doppler. In the third trimester, the biomarkers are the same. Plus, in the imaging, we have to do the echocardiography for the mother, as well as the uterine artery Doppler and the umbilical Doppler are very, very important because they can pick up the blood flow to the placental perfusion, and the chances of the fetus having fetal growth restriction can be measured. So now the preconceptional risk factors, what is the risk percentage? Chronic hypertension and renal disease, the risk is about 15 to 40%. Pre-gestational diabetes, it is 10 to 35%. Connective tissue disorder is 10 to 20%. Thrombophilia is 10 to 40%. And obesity and insulin resistance is 10 to 15%. Age, increased maternal age is 10 to 20. And limited sperm exposure, 10 to 35. And then family history of preeclampsia and cardiovascular disease. And women born as small for gestational age, they have 1.5-fold time increased incidence of preeclampsia and adverse outcome in a previous pregnancy like IUGR or abruption or intrauterine fetal death. So now what are the adverse impact of preeclampsia on the fetus and the mother? It is a double jeopardy. Upon the fetus, FGR, preterm labor, placental abruption, respiratory distress, cerebral palsy, retinopathy, prematurity, necrotizing enterocolitis, sepsis, and stillbirth can happen. Now, coming to the screening, what will be the ideal screening test? It should be simple, non-invasive, it should be rapid, inexpensive, easy to perform in the early pregnancy, and it should have high sensitivity and it should be predictive. Now, the screening tests that are available are regarding the placental perfusion and the vascular resistance. We can do a mean arterial pressure, rollover test, Doppler ultrasound, isometric exercise test, intravenous infusion of angiotensin 2, where there is increased sensitivity, platelet angiotensin 2 binding, platelet calcium response to arginine vasopressin, renin 24-hour ambulatory blood pressure monitoring. So these are all probably the screening tests. Now, coming to the biomarker, what should be the ideal biomarker for preeclampsia? You should play a central role in pathogenesis, be specific for this condition, appear early or even before the clinical manifestation occurs. This is the most important thing. Even if it is appearing after once when the clinical manifestations are occurring, then it becomes an irreversible condition. It should be easy, cheap to detect the detectable in the maternal blood and urine, show high sensitivity, specificity, correlate with the severity of the condition, should not be detected or very low levels in normal pregnancy. So this is the biomarker consortium timeline. Initially, it was started at 2011 and 2018 onwards. Now we have come to a standard biomarker. Originally, the first biomarkers were applied in 2012, which was FDA approved in 2015, and position paper came in 2015, second set of biomarkers in 2016, NICE guidelines supported it, and then Congress passes the 21st Century Cures Act in 2016, and NIH workshop, everything. All these biomarkers have started clinically applicable by 2018. So what are the types of biomarkers that are available? It should be diagnostic biomarker. It should be for monitoring, pharmacodynamic response biomarkers, or it should be a predictive biomarker, prognostic biomarker, susceptibility risk biomarker, and safety biomarker. So now let us see what are the biomarkers that are used in prediction of preeclampsia. Most important thing is SFLT1, placental growth factor, ratio of SFLT1 to placental growth factor ratio, PAPA P, pregnancy associated plasma protein A, placental protein T, 13, disintegrin and metalloproteinases, beta HCG, inhibin A, and soluble endoglin. These are some of the commonly used biomarkers which have a change in the women who are prone for preeclampsia. So why prediction is very important? Because the ideal screening test methods are preconception factors. We have to integrate with our prediction markers, pregnancy-related factors, the risk factors that are present pre-existing or during each trimester, markers, and the risk for recurrent PE can be as high as 35%. So when you are going to predict it and prevent it earlier, it can reduce substantial morbidity and mortality for both the mother and the fetus. So the biophysical marker is the MAP, which is commonly used, and the BP remains the cornerstone in early diagnosis. Also, it has its own limitation. Measurement errors can be associated with the sphygmomanometer, or effect of maternal postures on blood pressure in pregnant women can be there. Again, Doppler ultrasound allows the study of umbilical and uterine arteries for the prediction of preeclampsia. Association with preeclampsia, high umbilical artery resistance waveform, that is ST ratio, notching of the uterine artery waveform in the early second trimester, oligohydramnias, and uterine artery Doppler plus the biochemical markers are promising, but current data do not support the combination for routine screening. So by the time there are changes occurring in the Doppler ultrasound of the umbilical artery and uterine artery, or oligohydramnias is present, that means the rent has already occurred. No longer we can only have a secondary prevention or a tertiary prevention. So now the biomarkers, once again, the uric acid is found to be elevated. That denotes the severity of preeclampsia and perinatal outcome. Hyperuricemia, an early sign of renal involvement, occurs due to altered tubular processing, failure of the reabsorption. There is increased reabsorption where the serum level of uric acid ascends, and preceding the glomerular affliction, which causes albuminuria. So these are all the proposed hierarchy of biomarkers for preeclampsia based on robustness of the evidence. High robust activity is given to this angiogenic markers, that is SFLT1, PLGF, nitric oxide, renin, uric acid, human necrosis alpha, interleukin 6, insulins, and papain. And the second robustness is given to VEGF, ENOS, angiotensin 2, ACE, interleukin, and other things. And the third one is soluble P-selectin, ANG1 and 1 to 7, and interleukin 8, testosterone, androgens, and Notch family genetic predisposition, and cell-free DNA, and alpha-fetoprotein. So basically, this set of biomarkers are found to have a robust evidence. Then moderate to low evidence, we have so many things. Apart from this, among this microRNAs, I'm sure in days to come, it will be the top one. Then again, we have biomarkers that are based upon the trimester base. In early trimester, you can divide into 3 stages. In early trimester, SFLT1 to PLGF, insulins, renin, uric acid, nitric oxide, interleukins, PAP, and tumor necrosis alpha. That is the green one is the first trimester. And first trimester to second trimester, you have this orange one. And the yellow ones are the genetic tests that are available. So based upon this genetic factors, epigenetic factors, the angiogenic factors, you can have the inflammatory and endocrine system. We can have the biomarkers based upon the trimester also. So the beta HCG, which can be practically used, it can mid-trimester beta HCG levels correlate with the severity. Combination of beta HCG, maternal age, BMI, parity are superior in prediction of preeclampsia. Multifactorial model can help to predict preeclampsia with sensitivity of 70% and specificity of 71%. And PAPA is a 1628 amino acid proteases mainly produced by placental trophoblasts, and the fetuses with normal chromosomes. Decreased levels of PAPA in the first trimester is associated with increased levels of early onset preeclampsia, IUGR, SGA, and preterm birth. So PAPA in a baby having a normal chromosome, if it is decreased, it can be an evidence for early onset preeclampsia. Then placental protein 13, it gradually increases in normal pregnancy. It has got abnormal low levels in women who are likely to develop preeclampsia, IUGR, and preterm delivery. So all these placental proteins, they are reduced because the placental perfusion is basically altered in preeclamptic patients and the volume of the placenta is low. Fetal DNA, free circulating fetal hemoglobin is involved in the pathogenesis. Increased mRNA of fetal hemoglobin in placental tissue and free hemoglobin F are associated with increased risk of preeclampsia. Soluble SFLT1 is an anti-angiogenic that opposes the VEGF, that binds with the VEGF receptor. Elevated level is associated with the early onset preeclampsia, and it denotes the severity of the illness. Combination, that is serum SFLT1 binds with both VEGF and PLGF, thereby neutralizing them, displacing the VEGF and the PLGF. Subsequently, it will reduce their levels in the circulation, leading to all this preeclamptic complication. Soluble endoglin and leptin. Soluble endoglin is another marker which can be picked up in early, in the second trimester itself. So it is found to be increased 2 to 3 months prior to the onset of severe preeclampsia. Leptin, which is a product of OB gene, is produced in the adipose cell, and studies have shown high maternal leptin levels in the second trimester is of pregnancy in women who are expected to have preeclampsia. So soluble endoglins and leptins are found to be increased 2 to 3 months prior to the development of preeclampsia. Then comes the metabolomics as a diagnostic test for preeclampsia. Now we are all doing the era of proteomics and the metabolomics, where it can diagnose preeclampsia at a much earlier stage. Now, how we can prevent preeclampsia? First thing is primary prevention is contraception. Secondary prevention is aspirin before 16 weeks to correct the prostaglandin imbalance. Calcium supplementation 1.5 to 2 grams per day is found to be very protective in a population where there is low baseline calcium intake. Vitamin D3 supplementation. Tertiary prevention is by using proper antihypertensive, magnesium sulfate, L-arginine, and lycopene. So now we should never forget the Gestos score. When you are planning for a prophylactic aspirin, now we must know which are the group of people who should be started with the aspirin. So the aspirin dose can be 75 to 150 milligram, and it should be given mainly at bedtime. So that is the most important timing at which it should be given. And our ICOG has come out with a beautiful Justosis score, which we can have it in our OPD. And if the Justosis score is more than 3, then that means the patient has to be started on low dose aspirin in order to prevent the preeclampsia. Then again, evidence has been that to support the role of branched chain amino acid, which can promote fetal growth, increase the placental and the fetal perfusion. So this can also be given in women who are having FGR babies, supplementation with proper amino acids and good hydration to reduce the vasoconstrictor thing. Then this can improve the fetal weight. So the treatment objectives. So basically to the last part is how we can treat it based upon the biomarkers. We have to stabilize the blood pressure, prevent preeclampsia, prevent the complication, prevent eclampsia, and deliver a healthy baby at an optimal time. Restoration of the health of the mother in the puerperium, I should add up in future also. So for this, we have the common interpretation and plan of action using SFLT1 to PLGF ratio. And when you pick it up, this ratio, measure it, the PLGF ratio can be less than 38, or it can be 38 to 84, or it can be more than 85. So here, based upon the level of this ratio, if the patient has got the ratio of less than 38, that means the patient is unlikely to get preeclampsia in the subsequent 4 weeks, and this patient needs our routine follow-up. But when it comes to the question of 38 to 84, then this group of women with suspected PE or increased risk of developing complication within 4 weeks, and hence they should be followed up with 1 week. So if the level is more than 85, then the patient needs hospitalization, because at any time the patient can develop severe preeclamptic symptoms. So this particular ratio is ideal for us to base our treatment, when to deliver, what is the antihypertensive drug to be used, and how long we can postpone the pregnancy. So the interpretation is, as I said, less than 38, it has got a negative predictive value of 99.3% for 1 week, 97.5 for 2 weeks, and 94 for 4 weeks. So follow up in 4 weeks. And when it becomes yellow, that is 38 to 85, then we have to follow up every week, because the positive predictive value here comes to 36.7 for 4 weeks and 65 preeclampsia, and the adverse, preeclampsia or antenatal eclampsia can happen. Then again, when it is going to be beyond 85, it has got an impending adverse effects, and we have to have a close surveillance and hospitalization of the patient. So preeclampsia without severe features greater than 37 weeks, ideal is to deliver. If it is less than 37 weeks, then we have to have an expected management based upon the SFLT and PLGF ratio. And bed rest, it is no longer suggested. Serial maternal assessment, PP, symptoms, laboratory investigations have to be repeated every week, and watch for the weight gain, and daily urine protein should be checked. And serial fetal assessment with the NSD and biophysical profile, fetal kick chart, and have a serial ultrasound for AFI and growth, and Doppler studies have to be done. And oral antihypertensive drugs can be started. So in severe preeclampsia, if the patient has reached a stage of greater than 34 weeks, ideal is to deliver. If it is between 33 to 34 weeks, then maybe we have to give steroids to augment the lung maturity, and probably we can have magnesium sulfate can also be given as a single shot to prevent eclamptic complication, as well as prevent the complication, neonatal complications in the fetus. Then when it comes between 22 to 32 weeks, then it becomes very difficult, because the patient has to have a close surveillance, proper counseling, and we have to tell the patient at any time if there is fetal or maternal complication, the patient has to undergo termination of pregnancy. If it is less than 22 weeks, expectant management is usually not recommended, because in our setup, we cannot definitely save a baby less than this. Start magnesium sulfate, based upon the diagnosis, irrespective of the gestational age. Now, the common antihypertensive drugs that are used are labetalol and nifedipine. And when should it be started? When the systolic blood pressure is more than 140 or when the diastolic blood pressure is more than 90 millimeters of mercury, we have to start labetalol. Which drug we have to choose? That again depends upon the basic pulse rate of the patient. If you are going to choose the labetalol, if the patient has got a tachycardia, and nifedipine is preferable when, if the patient has got a tachycardia, choose labetalol. And if the patient has got a bradycardia, preferably we have to go for a nifedipine. So then what should not be done? No nifedipine should be given sublingually because it can cause sudden placental perfusion can drop. It can cause IUD and it can again cause dramatic reduction in the blood pressure and complication. Then AC inhibitors and ARB blockers should not be given. And if the patient is found to be an hypertensive prior to pregnancy, these drugs should be modified and changed to some other combined alpha and beta blocker so that it may not cause any anomalies for the fetus. This is what a chronic hypertensive patient should switch over to a safer antihypertensive drug. Atenolol and prazosin are not recommended currently. Now, the treatment of mild preeclampsia is you can have a combination of labetalol or nifedipine sustained release. The maximum dose you can go is 60 milligram of labetalol and nifedipine is about 40 milligrams. So though the textbook says it can be gone, you can go up to 120 milligram or 80 milligram sustained release in split doses. It is always safer to have a optimal level of one drug. If the blood pressure is not controlled, add up the other drug. But that is, for example, if with labetalol, if your blood pressure is not getting controlled with 200 milligram, that is 600 milligram per day, then probably it is safe to add up ideally the nifedipine sustained release tablets because the complications of higher dose of the individual drug may not be there. And hydralazine, which is a very good vasodilator, is found to be very effective. But when it is used for a longer time, it can be given in a combination with the beta or alpha blocker because the vasodilatation can improve the fetal weight. In severe preeclampsia or hypertensive crisis, we have to have a good drugs like hydralazine intravenous, labetalol IV, or nifedipine can be given per oral route, and use of sodium nitroprusside can be used in a very, very rare condition. So hydralazine 5 to 10 milligram, either 5 milligram IV or 10 milligram IM. Repeat the dose after 20 minutes and so that you reach the optimal level of 130/90. You see to that the blood pressure is not going much below that. Again, labetalol can be given with 20 milligram of bolus dose. We can repeat it after 10 minutes if the BP is not returning to normal, or maximum dose it can be 220, or switch over to other drug if there is an inadequate response. If you are going to give orally 10 milligram per oral route of nifedipine, it can be repeated after 30 minutes, and do not use short-acting nifedipine or do not use sublingual. Then remember, lower the BP promptly but slowly. Aim for a BP of less than 150/100. Loading dose of magnesium sulfate is recommended to prevent eclampsia in all severe preeclamptic patients, and then no need for maintenance dose here. Pregnancy can be safely continued after desired BP control. Expectant management is done at tertiary care center only if there is no maternal or fetal distress. Get time to use steroids for fetal lung maturity. So the timing of delivery, already I have discussed. Gestational hypertension at term, mild preeclampsia after beyond 37 weeks, severe preeclampsia after 34 weeks. In eclampsia, whatever be the gestational age, we have to stabilize the hypertension and stabilize the convulsion with magnesium sulfate, and steroids can be given. And steroids can be either dexamethasone or betamethasone, and cesarean section is done only for obstetric indication. And for other cases, for other patients, we can try with induction of labor based upon the Bishop score. Now, the crisis for preeclampsia, it could be eclampsia or HELLP syndrome, pulmonary edema, placental abruption, cerebral hemorrhage, cortical blindness, EIC, acute renal failure, and hepatic rupture. So how will you follow up the postpartum follow-up of this preeclampsia or eclampsia patient? Do not relax during postpartum because pre-eclamptic patients can turn postpartum eclamptic at any stage. So check daily BP, probably very frequently, once in 4 hours. If the BP is greater than 130/80, continue to use the antihypertensive. And if it is less than 130/80, you can stop the antihypertensive, but monitor intensively. And again, I would like to add a point that is furosemide can be given in the postnatal period after 24 hours of delivery in 10 milligram BID dose, which can hasten the reduction in the blood pressure and reduce the complication. Ask about severe headache and epigastric pain whenever you check the BP. So now coming to the risk of recurrence of hypertensive disorders of pregnancy, at any hypertension there is a risk of 20%, 21%, pre-eclampsia again 20%, gestational hypertension 22%. And pre-eclampsia at any hypertension, the chances are 14%. Then again 16%, 1 in 6 of birth, if it is going to be again pre-eclampsia recurrence or gestational hypertension, it can recur in 7% of the cases. And chronic hypertension, we don't have the appropriate data. So whatever it is, the future risk is if the patient pre-pregnancy, overweight and obesity, she can develop hypertension. Diabetes, she can develop any again hypertensive disorders. I always feel diabetes and hypertension are twin sisters. And again, hypertension can go for a small for gestational age, preterm delivery. So beyond, these are all the complications which can happen during pregnancy. In less than 10 years, similar to pre-gestational diabetic patient, these women are also likely to develop cardiovascular disorder, hypertension to much higher extent. In greater than 10 years, the chances of them getting CVD, hypertension, coronary artery disease, stroke, heart failure, and all-cause mortality is found to be very high. So we should think that pre-eclampsia is a marker for adverse pregnancy outcome, which we have to tell the patient that carefully she should be monitored to reduce the complications in future. So then finally, this is, I thought there are newer drugs which might come in future days, that is proton pump inhibitors, metformin, sulfasalazine, plasma apheresis, monoclonal antibodies, and genetic silencing. All this can be in future, we can have to prove a therapeutic intervention to reduce the severe hypertension. So future direction should be larger studies are needed to have the best biomarkers with better predictive values still need to be conducted. Research should also be conducted to fully understand the molecular mechanism of the disease and the importance of biomarkers in various processes. A study from Paris investigated the use of SFLT1 to PLGF ratio to improve perinatal care to reduce cost in the patient with suspected preeclampsia before 35 weeks of pregnancy. A study called PREMOM being conducted since 2021 aims to investigate the use of molecular testing in prediction of preeclampsia in women with early pregnancy. Currently, work is underway to use markers of EGF and its receptors like ProKR1, ProKR2, aquaporin fatty acids, and INC RNA, which are long non-coding RNA molecules that negatively regulate the gene expression. So the identification and treatment of patients at risk of preeclampsia is a rapidly changing field. Better prediction of preeclampsia and associated adverse outcome is still needed. Recently, many studies have been conducted on the introduction of angiogenic biomarkers to identify pregnant women at risk of preeclampsia. Use of biomarkers is increasing and has potential to improve the care and reduce maternal and fetal mortality and morbidity. And SFLT1 to PLGF ratio is better diagnostic performance than did a single marker, and it can also be combined with the uterine and the Doppler study. So it is a temporary organs tyranny, preeclampsia, the basic pathology, the abnormality of the spiral vessels, and then the hypoperfusion, and again systemic vasoconstriction with endothelial dysfunction, hypertension, edema of the brain leading to convulsions, proteinuria, and HELLP syndrome. So finally, I thank the delivery is the treatment, and when should we plan delivery to have a safe maternal and fetal outcome is the most important thing. And the right time for the baby and the mother should be there. And ultimately, I thank the opportunity given to me to share my ideas about the biomarkers in prediction, diagnosis, and management. Thank you.
Thank you, madam. Temporary organs tyranny. Yes, of course. Identification and interpretation and implementation is made understood, madam. Thank you very much. And to add more value to our discussion, if there are questions, I request our treasurer of KSOGA, Dr. Suman Gaddi, to check questions and then take over the questionnaire session.
Sonia, if you permit, I just want to comment on.
Yes, sir. We are looking forward for your comments, sir.
Dr. Ramani, it was an
Sir.
excellent presentation. I congratulate you and I sincerely thank you for responding to our short notice to be there today and also given a really new insights on various aspects and future areas on this. I just want to tell you that in India, the biomarkers are currently available or made of only the Roche kits. And now we are going to have a shortly one of the big trial on the biomarker, mainly on PLGF. So there the category is normal level, abnormal level, and very abnormal on PLGF. But the PLGF is not from the Roche kit. It is going to be from the other kit because they are tested and standardized. That is the libs and the Ronia kits are available, and the libs is the one of the best on these. So I mean currently available data on that. Mainly the PLGF is used in our setup here, but in Europe and the Western world they are using mainly currently on PLGF because SFILT is an anti-angiogenic, whereas the PLGF is an angiogenic. It itself tells. But only thing I am concerned is about the prediction. The level of PLGF in the first trimester, what we use, we are not certain. Some areas they say 30 picograms, and some are saying up to 50 to 60. But in some cases, it is even more than 60 also, they are predicted that increased risk of preeclampsia on the other markers. So it should be whether PAPA combined with PLGF, because in the marker test, we use this both PLGF and PAPA. So whether that should be used along with the uterine artery, and maybe the PLGF will tell us where we stand. So I just wanted to know that what markers have you used in your practice, because we have got in our institution the Roche kit. I had discussion on this Roche kit. The PLGF levels are totally different over this. So I just wanted to know.
Yeah, I have tried with PLGF earlier, sir. Isolated PLGF level, I was not very happy. But the combination of Doppler studies in the late trimester, I mean first trimester end, or in the early second trimester, that could somehow predict. But maybe in days to come, we have to have a better research work oriented to this SFLT1 ratio with PLGF. That might be useful. But I always feel instead of a single biomarker, a combination of biomarkers with a practically available uterine and the Dopplers can help in predicting the preeclampsia in much better way.
Do you have any, do you have read? Because I generally use in resistant cases in very early onset preeclampsias when they had this, I use the statins. And some of the results are promising, but STAMP trial where the statins to ameliorate the preeclampsia did not show that that important ones. But statins really help in the resistant or early onset preeclampsia. We have used in few cases, but I'm really happy with that. But
Okay,
unfortunately,
but then the
we don't have-
statins, we have a controversy of using statins during pregnancy also, sir.
No, beyond 12 weeks, 13 weeks, we can
Okay.
use that
Okay.
rosuvastatin of up to 20
Yeah,
milligram.
probably rosuvastatin can be tried.
Thank you.
Thank you, sir. Thank you for adding icing to this talk. Some of the facts what I didn't know.
Thank you.
Thank you, sir.
So, good evening, everyone. I'm Dr. Suman Gaddi. Actually, I'm not seeing any questions in the chat box. Madam Ramani Devi, excellent talk. And of course, you highlighted so much about the biomarkers. I would like to know, apart from this PLGF, what are the biomarkers you are using, madam, for the prediction of preeclampsia?
No, madam, I'm not using any biomarker practically. Only after preparing this, I thought we should use more and more of biomarkers.
And the availability in our country, this PLGF-OK regarding Papa A and PP13.
Papa A is available, madam. Papa A is available, yeah.
Yes, ma'am. And then regarding, could you please highlight a little more on the what is that? Metabolomics.
This metabolomics, that is proteomics and metabolomics are some newer, I mean, it's not exactly the biomarker. These are the techniques which can pick up earlier the onset of the women who are likely to go for a preeclampsia. That's all.
Okay, madam. Just now you mentioned that rather than one single biomarker, combination of biomarkers are better in predicting preeclampsia. I would like to know the combination.
See, that is what we have mentioned about the mean arterial pressure, the uterine artery Doppler, Papa, and then PLGF. All these things can put together and predict the onset of risk of preeclampsia in the first trimester itself.
So rather than one, all these four you prefer.
Together. Yeah.
Okay, ma'am.
So somebody has asked, is it affordable to use biomarkers? I think PLGF is costing only 1,000 rupees. If you can prevent it, and the value of the PLGF, if it is off, it can predict preeclampsia. Probably we can, for prevention of severe preeclampsia, we can try that. We can use it. The cost is 1,000 rupees in our place. PLGF alone.
So I think for this topic, that was the last question that was asked regarding affordability of the biomarkers. And if anybody else have any...
Can I tell that right now, Suman, the cost is high because they are not been done in every place. And these are some of the companies are only doing,
yes, company.
etc. They are charging 5,000 plus. So once that comes, and what we are doing the now study with the point of care test, how you are doing now pregnancy test kit, it will give that one drop of blood, like blood glucose levels, how much it is showing. That type of kits are available, and they are going to be in place in next few years. So maybe 2 or 3 years, you put one drop of a hypertensive woman, you come to know what is the level of PLGF or what is the level of SFID to PLGF level ratio. So that era we are going to go in. So that's why this talk was arranged to create awareness.
Similarly, sir, microRNAs definitely it will come into vogue in future, sir, because the woman who is prone for early onset endometriosis, they have dysregulation of certain microRNAs, which can be picked up from the peripheral blood. So in a family who has got a very high chance of developing preeclampsia, if the mother and the sisters are having preeclampsia, then to that index candidate, probably these microRNAs can come for our help in future.
Yes, madam. One more question by Dr. Shubharani. Ideally, when should we test for the biomarkers?
So probably in any justosis score, we are measuring in any high-risk patient at the first time as 13 weeks of pregnancy, we start doing that. Quadruple test. Quadruple marker test will pick up.
Yeah. Another thing, Suman, is AI is going to help here because Justo's score is too vast. It is very high. You need to have the proper history of record and put this to the AI device, and that should tell you whether this patient is high risk and need to test the biomarkers. Maybe we are going to have AI on this, which will help definitely.
So another question by Dr. Varsha, ma'am. Can we also use hemodynamics like cardiac output or 2D echo to predict the PE?
See, that is what I told earlier. Some of the echocardiographic changes, they are very specific for preeclamptic patients, and you can differentiate from hypertensive disorders. In preeclamptic patient, they can have some sort of diastolic dysfunction, plus there can be pericardial effusion, but whereas in a chronic hypertensive patient, the left ventricular muscle mass is slightly found to be increased, with almost most of them have got a normal LV function, unless it is a very, very long-standing diabetes. So, I mean, long-standing hypertension. So, these two that we have been doing for years together, this echocardiography for hypertensive disorder of pregnancy, and we have found out that like patient having ascites or pedal edema, pericardial effusion is also more common in preeclamptic women when compared to chronic hypertension. And left ventricular muscle mass is another factor which can differentiate. So anytime if you do a echo, it can help you to differentiate chronic hypertension from preeclampsia, because all of us know, we know that chronic hypertension has got slightly a better outcome than that of the preeclamptic patients.
Suman, I want to share with Ramani that we must congratulate Tamil Nadu. They are the ones who are started with the routine 2D echo at least once in pregnancy, and that is going to detect the peripartum cardiomyopathy, number one, and the concentric hypertrophy of the left ventricle, which is the early sign of preeclampsia. They are doing this, I mean, preeclampsia. So I must say that Tamil Nadu is a pioneer on this, and the first people to start routine echo in pregnancy.
I myself have got more than 2,000 patients, antenatal patients with an echocardiography report. I am planning to condense all those things and come out with the results.
So yes, madam, you are doing it in the second trimester? Echo?
Preferably, it should be done at the first trimester itself. Earlier, they were telling we should do it at the second trimester. Now we want to do it at the first trimester because in cases of this undiagnosed multivalvular lesions, termination is possible if we detect it at early trimester.
Chronic hypertensives, we are doing it preconceptionally.
Definitely. These are the group of people who need preconceptional evaluation.
Yes.
We should assess whether it is a primary chronic hypertension or whether it is secondary to renal problem or adrenal problem or any other coactation or so many other things.
I feel every antenatal card should have a Justo's scoring.
Yes, that we make it a routine, madam. In all our antenatal cards, we have a Justo's score. So the staff will give a tick, and she will put the Justo's score is 3+ or 4+. Then we start using the aspirin. So now off late, I find very severe preeclampsia, patients culminating with eclampsia has come down dramatically.
One more question, madam. If patient is not started on a echosprin before 16 weeks, will it help if we add aspirin later to prevent T?
Ideal is to start much earlier, but at least because the reason why they say it should be started prior to 16 weeks is to promote the secondary wave of trophoblastic invasion. But once when we misses, probably the effect may not be that good as starting aspirin at a much earlier stage.
But it can be added.
It can be added. It can be added, definitely. It is better to have something than nothing.
Yes, madam. I think the question answers, I think that was the last question, which I'm seeing in the chat box. Very well done, madam. A very nice presentation.
Thank
And
you.
so many things you have highlighted, so many new things, of course, which is going to come up in future also and help the pregnant patients uh, to detect this PE early and reduce the mortality.
Yes.
Suman ma'am, one take-home message from Dr. Bellet sir and Madam Ramani, that for today and tomorrow's practice, in conclusion, could you just give us one checklist, ma'am? As we know, biomarkers are still in the process.
Sir,
You are giving first, Ramani. I will give later.
I think we have to check the blood pressure of the patient personally. Don't rely upon the staff nurses. And then if you find it that it is going to be high, repeat it. Then these are the people who need follow. So proper follow-up, identification at the earlier stage, proper treatment will definitely helps to reduce the maternal mortality, morbidity, and neonatal mortality. So you have to have what the mind knows, only the eye sees. So that we have to have that sharp thinking that who are the patients who are likely to enter preeclampsia.
Madam, one doubt. The nurse in the periphery sees the blood pressure and always it will be showing normal values. The patient within a week or so comes with eclampsia to our, center. So that's what you told, a very good point, that we ourselves should check the blood pressure rather than relying on the nurses. We do not know when the blood pressure was high earlier, but when she comes here, if she comes in, serious condition in conversion stage only. So
yes, weight gain, madam.
Hmm.
Invariably, I have seen these patients putting on weight 2 kilos within 15 days. They will come bloated. Occult weight gain is another important factor where we have to make a note of them.
Yes, ma'am.
My message would be the second trimester mean arterial pressure, uterine artery, the pulsatility index, apart from the gestational score, whatever they are having. These we carefully look at, and any hypertension which develops beyond 20, the biomarkers will definitely help. Currently, we are not in the biomarkers at that commonly used. Maybe in another 1 or 2 years, these biomarkers will come in a big way, and that is one important thing. And please do at least one echocardiography. It's not the guidelines still available, but we need to do the echocardiography because we also found that in preeclampsia versus normal controls, we saw that diastolic dysfunction is observed in a normal pregnancy also. It gets exaggerated when there is an excessive fluid load, so that may be peripartum cardiomyopathy. Or if it is preeclampsia, there is more than 60% diastolic dysfunction. It is very critically noted, and unfortunately, we have not been able to publish yet. One of the journal rejected that article, so we are in a second journal. We are processing that. Thank you.
Thank you, sir.
Thank you very much, madam. Dr. Ramani.
Thank you.
Sonia, madam.
Thank you very much, ma'am. We have actually had some technical issues. Our first speaker, Advocate Dr. Hitesh Bhatt, sir. Now, Dr. Hitesh Bhatt is online. Bellet, sir, do we request sir, because sir has had some problem sharing his slides.
Now he can speak just like that.
Yes.
Okay.
Keynote address at least from
Yes.
Dr.
Yes.
Hitesh Bhatt.
Definitely. Hitesh, please go ahead.
Okay, sir. So I would like to
if I can, I will show you my video like this. If you can see this, right? So we were talking about the medico-legal issues. The medico-legal issues are constantly increasing our practice, and the subject which we don't know is the law. We learn so many things, but we don't learn the law. So we are facing many medico-legal issues. Now, what is medico-legal? Medico-legal, there is no term like medico-legal. It is any issue where doctor is involved, any legal case where doctor is involved. That case is called medico-legal case. There is no specific case. So by that definition, every case is a potential medico-legal case. If doctor is involved either as a witness or as an accused, that case becomes a medico-legal case. And we doctors have habit of coining such terms, and that is why we have coined this term medico-legal. Actually, there are no such journalist or legal. They are also under the ambit of the law. But we as a doctor are coining new terms, and we have coined this word medico-legal. So medico-legal case is nothing but any case where a doctor is involved either as a witness or as an accused. Where all a complaint can be filed against the doctor, there are various places where a complaint can be filed. In the either as a consumer litigation, criminal litigation, PNDT related, MTP related, medical council, human rights, complaint from the Pollution Control Board, or ART in Surrogacy Act, birth and death registration, so many places where a complaint can be filed. And medico-legal cases are constantly increasing. And they are increasing almost by 100% every year. I have started my camera of my second login, so you can see my slides there if you just put it, if you just pin that camera. Yeah, so the medico-legal cases are increasing, and the reason for increase is awareness due to media and internet, decreased threshold of the people in the society, and change in doctor-patient relationship. And there are many things which can happen. Like, see, in this case, you feel that there is somebody whom you can handle, but that comes to you as a shock, right? Or many a times we kick the wrong ball, medico-legal problem starts. So we are living in a situation where doctor and patient are happy till the time the things are good. The minute something goes wrong and the patient starts dancing on the head of the doctor. Why this was not done, why that was not done, so many questions. So first we have to understand what is negligence. Negligence is defined as to do something which a prudent man in similar situation will not do. That is called act of commission. I will give you an example. If suppose just now we have heard a lecture, if patient puts on weight 2 kg in 15 days, you have to get alerted, you have to do something. If you don't do that, that means you are doing something which a prudent doctor would not have done. That is called act of commission. What is act of omission? Not to do something which a prudent man in similar situation will do. Suppose a patient comes to you and in your OPD, she has breathlessness and her oxygen saturation is going down from 100 to 80 to 60 to 40. You cannot watch her dying. You have to do something. If you do not do that thing, you are negligent for act of omission. So act of commission and act of omission makes you negligent. And what prudent doctor would have done, that who decides? That is dependent upon your medical books, your textbooks, what your colleague would have done. So if your colleague says that I also would have done the same in similar situation, you are not negligent. So the court also relies upon so many things, some journals, medical literature, opinion of the board. Why opinion of the board is taken? Just to ascertain that what other colleagues would have done in this situation. If the board says that whatever treatment was given was perfect and we also would have done the same, you are not negligent. So after understanding that, let us see what are the common mistakes
are which can the responsible for medico-legal problems. I have seen in my practice these are the issues which can lead to medico-legal problem. First is improper communication. Communication is for two things: consent and charges. If you are not clear on either of this, the medico-legal problem is surely going to happen. Second, by colleague. Third is rough behavior of the staff, unexpected result, and non-compliance of the law. We will see certain these examples. First is consent. Now, what is consent? Consent is nothing but it is basically a counseling. And whatever you counsel to the patient, when you document it, it becomes a consent. So it is basically a documentation of the counseling is called consent in a written form. So you have to counsel the patient, and counseling is very important. If you say whatever is going to happen to the patient in percentage, and if that thing happens, patient is ready to accept it. But if something happens suddenly, then patient cannot or may not accept it. So always tell them certain risk in percentage, always promise less and deliver more. Remember this thing. And always talk more in the consultation room. And it is said that it is always better to talk more in the consultation room with the patient rather than talking in the courtroom against her. So always talk more in the consultation room. I'm skipping certain slides. Now, good communication is not just necessary to prevent yourself from medico-legal problem. Good communication is a reflection of good care. There is a case of Samira Kohli versus Dr. Prabha Manchanda. This is a landmark case where it is mentioned that what a consent should be in the Indian context. And this case, the judgment was delivered in 2007, and the Supreme Court very categorically said that there are certain principles related to consent. And they said we have what are the parts of consent? Consent should say certain things. First, it should be real and valid. Real and valid means it should be a free consent. That means patient should not be put to gun for to take a consent. That means it should be a free from coercion. There should not be fraud. There should not be misrepresentation. If patient asks, doctor, something will not happen to me, no, nothing will happen. That is misrepresentation. Undue influence. Never show undue influence. Your mother also delivered at my place. Sign this. That is undue influence. Don't do that. So that is not a free consent. So consent should be free from all these things. Second thing, capacity and competency to consent. That means the person signing the consent should be major, should be sane, should not be under influence of any drug or anesthesia. Then, and major person means more than 18 years of age. Then consent should be for lawful object and lawful consideration. That means your object should be lawful. Patient cannot give consent for euthanasia. Patient says, okay, doctor, kill me, I want to die. That consent is illegal because the consideration or the object is illegal. And adequate information should be given to the patient. What is adequate information? Got further clarified. Adequate information means you have to tell the nature and procedure of the treatment. So if you are taking consent for cesarean, you have to tell that usually the birth happens from the genital tract and the vagina, the child comes out, but we are going to cut open the abdomen. You will cut the uterus, we will take the baby out, we will suture everything. That is called nature and procedure. Purpose of the treatment. You have to say that the bones are there which are which are not allowing the child to come out. There is the CPD you have to explain if you are doing it for CPD. And you have to say that that is why we are taking this diversion and we are taking the baby out from this route. That is purpose you have to explain. Benefit you have to explain. There won't be any fetal distress. There won't be any rupture uterus. There won't be any maternal distress. That is benefit. Alternates you have to tell. We can go for trial, but in trial, these are the risks which can occur. Outline of substantial risk. While doing cesarean, there can be PPS, there can be fetal distress, there can be infection, there can be bleeding, there can be injury. All this you have to explain. And adverse consequence of refusing the treatment. If you will not go for this, there are chances of rupture uterus. You have to tell everything. So practically, each procedure has a different consent. The consent for cesarean cannot be consent for hysterectomy, cannot be consent for laparoscopy, cannot be consent for tubal ligation, cannot be consent for cyst aspiration, cannot be consent for fetal reduction. We are taking only one consent, that is called blanket consent. It was discontinued in 2007. If you are still taking the same consent where you are changing the heading and rest of the things are same, then you are lagging behind only by 17 years in your practice. So consent is nothing but what villain is trying to do with the heroine in a Hindi film. Hero does the same thing. The only difference is of consent. So you have to understand consent. Then we have made procedure specific consent for 13 branch of medicine and we have put it online. That is consentfordoctor.com. On this website, we have put all the consents. Now, we are not discussing cases because time is less, but if there is any question or any time is there, permit me, I will tell you certain cases also. Second thing is you have to remain clear on the bill. Many a times if one doctor has told patient that there will be 70,000 rupees. When patient goes to another colleague, he will say, I will do it for 40,000 rupees. But at the time of bill, he will add medicine charge, nursing charge, doctor round charge, OT charge. Ultimately, a patient will end up paying 80,000 or 90,000. That is not correct. You have to give a ballpark figure. You can't give exact amount, but at least you can say rough figure. And also you can say that there can be plus or minus 10% or 20% or 30% in case of emergency in certain cases. But you have to remain clear on the bill as far as possible because most of the problem in the world are happening because of money. Even Ambani brother had fight because of money. So money is something which you have to be very clear about. Then comment by the colleague or comment for the colleague and rough behavior of the staff. There is a case of Dr. Anil. What happened? One patient came to Dr. Anil. He is a gynecologist and he said that doctor, I have got sterilization done 5 years back, but I have missed the period. You just check me. Doctor checked her and she was found to be pregnant. So doctor said, this is failure. You are pregnant and I will do termination. She said, doctor, can I file case against that doctor? Dr. Anil said, no, why to do that? I will give you some concession. I will consider your case. Don't worry. Then after examination, she again asked, sir, can you give something in writing that this is negligence of the doctor? He said, I can't do that. Again, while going, she said, doctor, we will pay you, but can you give your opinion that this TL is not done properly? He said, I cannot do that. And he was curious. He said, can you tell me where this operation was done? She said, sir, you only did it 5 years back. See, patients are that smart nowadays. This is a real case. So please be very cautious while giving opinion against your colleague to any patient. And this is what happens when two of you fight. When two of us fight among ourselves, the third person will definitely win. So never let that thing happen. And in 40% of the litigation, rough behavior of the doctor and hospital staff is responsible. And I will give you a simple example. See, at your home, all those who are married, they will understand this. That if you are caught doing something wrong, suppose you are not listening to your wife, you are not doing according to her advice, you have not done some work, homework, which was given to you, you forgot to bring something from the hospital while coming home, you forgot to bring vegetables or something. She will tell you, you will always on a mood to take revenge, right? That okay, you also forgot it today. That is what is happening with the patient. If you have showed some rough behavior, will sit on your head and will file a case. So keep your behavior modest. Unexpected result. We know that unexpected result can occur. We have no control over it. In the best of the hands, it can occur, but it should occur as a chance and not because of the negligence. We have to explain that chance to the patient by way of consent. And that is why I said always promise less and deliver more. And also try to learn things, try to make yourself remain in practice so that things don't go wrong. Always learn things, be in practice, read good books, and you will be in touch with the common routine practice. And ignorance of the law. That happens quite commonly. Laws are made in the parliament. This is what is the gazette. When it is gazetted, it is believed that every citizen knows about it. Many a times doctors are telling, but sir, I don't know it. Form F not signed for sonography, machine is sealed, doctor is put behind the bar, and they come to me, sir, I have been jailed, what to do appeal. But if forms are not signed, how can I save them? If it is not signed, it will remain not signed. You must know the law, you must read the law, and you must understand the law. Because ignorance of the law is never a defense. I cannot say that I did not know the law. Like there is a law, you cannot murder someone, right? You cannot cause homicide of somebody. You cannot kill someone. Since my birth, nobody has come and told me that murder is a crime. It is my duty to learn it after my birth, even though the law was passed before my birth. So it is your duty to understand the law. Ignorance of the law is no excuse. And what is the role of court? Courts are there to interpret the law. Court just interprets the law. Court cannot make the law. So for all the doctors, what are the laws under which they can be punished? There are more than 150 acts under which a doctor can be implicated. Establishment Act, Biomedical Waste or Environment Protection Act, Drug Act, Consumer Protection Act, Civil and Criminal laws. And for gynecologists, there are few more over and above this: Birth and Death Registration, MTP Act, PCP and DT Act, ART and Surrogacy Act. And as a citizen of India, all other acts are applicable. Suppose you treat a patient who is a foreigner and without any medical visa, you treat them and you indoor them, you are infringing the Visa Act of India and you can be punished. So you can be under, it is like giving shelter to any person who is not having a visa. So any citizen of India can be punished for the same. Same way it is applicable to you. So we are under ambit of all the laws which are there in India. So at least the laws which are specific to the medical practice, we must know and we must understand. Law will never teach you medicine. Many a times the question is asked to me, sir, can in this situation I do cesarean? In this situation, can I give this treatment? Law will never teach you medicine. Understand? Law hardly teaches law. How can it teach you medicine? No legal book ever mentions what treatment is to be given in eclampsia patient or what treatment is to be given in a cesarean case or what treatment is to be given in a diabetic patient. But medicine may teach you law. If you do not learn it by some such CMEs, you will get caught in some case and then you will start reading the law. That should not happen. Learn the law before something goes wrong. How to save yourself from medical legal problem? There are certain do's and don'ts. Always have insurance. That is very important. Many doctors, I have started a new group for medical legal discussion where I'm going to give certain tips. In that group also, when I did a survey, almost 100 plus doctors from that group, they are not having insurance and they are practicing. That is very sad state of affair. They don't drive car without insurance, but they start a practice without insurance. That is very surprising. So have insurance. Try to avoid medical legal problem because insurance will pay for the money which you are losing over the case, not the time which you are giving. Because when case starts, you might be looking like this, but when case ends, you start to look like this on the right hand side. So always try to avoid the case. Always obtain consent before the procedure. Document everything properly and meticulously. It can be handwritten, it can be typed, it can be computerized, whatever way you want to do, but always document properly. Visit your indoor patient regularly and make a habit to enter in indoor records. I am seeing case paper, I am auditing case papers, and what happens? Doctor says, I have seen patient 5 times, but written only once or no post-op finding. So it is always better to write it whenever you see the patient, then only it will be believed. It will be considered that you have seen patient once. So always write everything. Law always requires evidence. Never alter the record, because whatever you do, you cannot make tiger out of an elephant. Good documentation is a good defense, poor documentation is a poor defense, and no documentation means no defense in the court of law. So more good your case paper is, more perfect your case paper is, there is always a good defense on your side. Always examine female patient in presence of female nurse or a relative. Never do this. Always have a female staff together, and never do this. He is trying to check the mobile, his messages, and she feels that he is taking a picture. Never make any gesture which leads to doubt in minds of the patient. Never give guarantee about the result. As I told you before, beauty can convert into beast, and beast can convert into beauty in no time in our practice. So never give any assurance about the result. Always say that I give assurance about my efforts. I cannot give assurance about the results. Karmane vadikaraste ma phaleshu kadachana. Always accept the patient for the treatment within your limits. If you cannot do certain things, don't do it. If you cannot remove grade 3, grade 4 endometriosis through laparoscopy, don't do it. Just by looking in the conference, just by attending 1 or 2 conference, don't telling in my legal practice also that if some case comes to me for Land Requisition Act or Banking Act or Corporate Act, I say that, sir, I don't know this law. You have to tell, you have to accept your limitation, you have to excel yourself in one direction in which you are master. No cross-pathy practice. In lookalike condition, always take second opinion. Don't hesitate to do so. Review the textbook and articles to remain in tandem with the current practice. Always accept patients' or suggestions. If they say, sir, can I take second opinion? Okay, take it. Sir, can I get one more sonography done? Do it. If something is possible to the extent, always follow patient's advice. Don't try to oppose them. Give follow treatment to the patient who has given you the notice. And also, yes, hello, yeah, can you hear? Figure out, we are obstetricians, right? So from the fetus, we can make out which fetus is going to become Puspa. Similarly, we can make out that which patient is going to be litigant. The one who is asking more questions, one who is never satisfied, refer such patient to your nearby colleague, right? If you get legal notice, always take medical, legal and medico-legal advice, because all three of them have to fight your case together. That is the way you will get the proper result. Do not panic. You are going to get some medico-legal case against you. Do not panic. Do not keep concentrating on a problem which has happened. You may harm the other normal case, right? Sometimes we look for the things very far off, but actually it is very near. Similarly, just continue your journey, not only walking, but dancing like person are out of the scope of any law. Only two. The one who is not born and the one who is already dead. We are neither of this. We are in between. So we have a threat of any kind of litigation. So do not fear. Have fearless practice. And I always say, to have fearless practice, you must practice to remain stress-free. Thank you very much for patient hearing. Thank you.
Thank you very much, sir. Indeed, I think it was wonderful with the slides what you had prepared for. But it was really task for you, I guess, because keeping it on screen and speaking over the phone.
That's okay, but I think I could deliver with whatever resources I had. And
Sir, I'm sure there is a lot of questions from the participants, but only thing the paucity of time, we would probably not do justice to the questions asked. Suman ma'am, are you there?
Yeah, hello.
I'm here. There are two questions in the chat box.
Yeah.
Yes.
One is Dr. Arif says, for OPD, should we keep records?
Yes, we have to keep records for OPD or for any kind of practice. Right?
Then the next question is, can we keep Xerox of OPD sheets?
Rather, you give Xerox to the patient. OPD records are or indoor records are the property of the hospital, but patient has a right to get it. So patient can get it by making an application, but you must have original, because when the case goes in the court, you will be asked to present the original in your defense, and patient will surely not present that.
Next question is, for off-label medicine use, can we use just consent form or ethical approval is required?
No, for what purpose you want to do? For research purpose, ethical permission is always required.
No, routine,
Otherwise,
because the previous questions are OPD related, probably it is OPD treatment.
so in OPD treatment, you can always give. There is nothing wrong in that, but it has to be approved by some journal, or it should be approved by some way. You can't start your own research on that. So there has to be something in the textbook or something in the journal where the use is there. If it is totally for the first time you are doing, then you can't do it.
Yes, sir. Then next question is, as many of doctors are using medicines which are not in recommendation. So can we use this off-label medicine? The next
What
they're
is
asking.
not in recommendation? I'm not getting it. If it is not recommended, how can we give it? There can be two school of thought. One school says you give, one school says you don't give. In that case, you can give, you can remain stick to any one school of thought.
Okay.
But if everybody is telling don't give, then you can't give.
So which are not on recommendation should not be given. Okay, sir. So
It should
that
be
is
recommended. It should be recommended by any one of the bodies.
Yes, sir. Yes, sir. So I think that was the last question in the chat box. Thank you so much, sir. That was an excellent presentation. Of course, your take-home messages were also very good. And I would like to know if any others are having questions.
Dr. Hitesh,
yes, sir.
It is fantastic presentation, though there were some hitches were there, hiccups were there, but you are the best on that presentation. Slides hardly matter for you, it looks like that. So,
yes, sir.
But you are amazing on this. Only thing I just want to say, endorse your statement, communicate, consent. I think that will safeguard us in a better way and document that what you have done. I feel so. Thank you so much. It is very important.
Thank you, sir. And sorry for all the trouble.
So one more last question, sir.
Yes.
Nowadays we have this video consultation. So even in spite of taking a video consent, should we also in addition take a written consent?
Written consent only has to be taken. Video consent I never recommend, because you cannot talk everything. In writing you can have 60 things written, but in video consultation neither you will have time, nor you will have that much knowledge, nor you will have that much memory to say or to speak about that complication. And if that will happen, it will go against you, that you have not told it to the patient. So if it is not recommended by law, never overdo the thing. Always remain stick to the hard copies. And consent is nothing but a contract. You are looking at a surgery done for 1 lakh rupees or 2 lakh rupees, right? And we are talking about video consultation. When you purchase a flat or your hospital for crores of rupees, which builder has taken your video consultation? That I am going to give you this many square feet, I am going to give you these facilities. Which builder for crores of rupees is taking a video consultation of yours? He is just giving you everything in writing and you are documenting that 60-page document. Same is with the consent. Why we are concerned about video consultation?
Okay, sir. Right, sir. Thank you so much.
Sir, you mentioned about the OPD records. How long the OPD records have to be preserved, sir?
See, various laws has various timeline. General guideline for Medical Council Act is 3 years. But if it is record pertaining to infertility treatment under ART Act, it is to be kept for 10 years. Under Surrogacy Act for 25 years. And under PCPNDT Act 2 years. Under MTP Act 5 years.
She pinned it.
So for clinic practice, it is going to be very difficult, sir. Hospital practice, OP, I think it is okay. But clinic
You
practice,
see, madam, documentation is the way forward for any field. When if you see, when you must have taken loan first time 15 years back, there were 30 pages you were signing. Now you are signing 150 pages, right? For any document, for anything, income tax return was 4-page document. Now it is 15 to 60 pages document. So everywhere the documentation is increasing in every field. We are no different from the society, right? So we have to adjust somehow.
right. Thank you, sir. Thank you, Suman ma'am, for taking up that questions. We have a lot of other questions related to the legal concerns related, sir. But then indemnity, POXO, there are a lot of things. I think
These are all one lecture.
yes.
This is,
So with the if our Dean Dr. Bellat and the KSOGA and KCOG family allows, probably we'll have some more sessions with good internet connectivity and with no glitches, and very interactive questionnaire sessions. We look forward to meet you again on screen sometime at the same platform, sir.
sure.
Hitesh, we will try to accommodate and call you for our state conference. I will speak to Dr. Durgadas and Bharti. If
Sure,
there is physically, you can be there, and it's an important session.
Sir,
I think
I'm here for conference only, Kerala conference.
I know.
And that
Karnataka
is why,
state is in
yeah.
October 31st to November 2.
Sure,
So
sir.
I'll request Durgadas if there is a time on the first or second day, it would be we will be happy to have you.
Sure, sir. My
If
pleasure, sir.
you are available. If you are
Sure,
available.
sir. Sure, sir. We will adjust the date and we will do it, sir. No problem.
Thank you so much, Hitesh.
Okay, sir. Thank you, sir.
Thank you.
I come to the end of this webinar. Very informative talk by both the speakers. Do we summarize on this, Bellat sir? If Dr. Vidya is also around, I just don't see madam. I think she lost her connectivity. Madam, Dr. Vidya? And I doubt madam is around. Sir, with your permission, do we end this webinar?
You can summarize, Sonia, and we sincerely thank both the speakers for the valuable contribution. I think you summarize and conclude today's webinar.
Yes, sir. I'm very thankful for KSOGA and KCOG family who's created this platform for continuing medical education. Many more to go, but then let's take forward the key learnings from today's sessions from both the speakers. And we continue to strive for excellence in maternity and the neonatal care, always and every time. Thank you for all participants, attendees, and consultants, and special thanks to our postgraduates. But then we need many more questions in the chat box in the next future webinars we conduct. Thank you so much. Special thanks to our technical experts behind the screen, Mr. Arun, for all the connects. Thank you so much. Thank you. Thank you, sir. Thank you, Bellat sir. Special thanks because it was possible for us to get the speakers only because of your connects. Thank you.
No, not like that. It's okay.
Thank you very
Everyone's
much,
efforts.
sir.
Thank you so much. Thank you.
Thank you, sir.
Suman Ganiman, thank you so much. We'll have many more sessions then. Thank you.